We're going to be talking about identifying the pre-ectatic cornea. Is this patient a good candidate for LASIK? Does this patient have a corneal ectasia? How about this one? Which of these eyes developed ectasia after LASIK? Which of these eyes progressed to frank keratoconus? My mentor and friend, George Waring III, told me there were 3 key elements to giving an effective presentation. You should first tell the audience what you're going to tell them, then you should tell them, and at the end you should tell them what you told them. So I'm going to start off with the end, and our take-home points today are that while we still have much to learn, we understand corneal ectasias better than ever before. We have the ability to identify corneal ectasias better than ever and at earlier stages than ever before. However, accurate identification of these patients requires great training, technology, and effort on the part of the physician. There simply are no shortcuts. So what are big steps that we've had in our field in ectasia identification? There's certainly too many to enumerate in this short period of time, so I'm going to focus on 3. Corneal epithelial mapping, recognizing corneal ectasia as a focally focal disease process, and recognizing corneal ectasia as an inflammatory mediated disease, at least in part. If we consider Pachymetry 1.0 to be single point measurements of corneal thickness, there were great advancements when we moved to regional corneal thickness measurements that were not only global in their coverage, but also reproducible. But Pachymetry 3.0 really includes epithelial thickness mapping and all of the different things that we can learn about the cornea simply by looking at epithelium. Really credit goes to Dan Reinstein, who pioneered work with the very high frequency digital ultrasound, and David Wong. Certainly many other people have been instrumental here. But David did work with the OCT. We looked at the variability between normal patients and patients with ectasias years ago. When you look at epithelial mapping in patients with keratoconus, it follows a logical progression where the epithelium thins in the areas that are steepest. And it can really be diagnostic almost unto itself. The remodeling of the epithelium is truly incredible in early disease, in later disease, and even in very advanced disease. The information we get with very high frequency digital ultrasound and OCT is very similar and analogous. And in the United States today, we have 3 separate devices that are approved for regional epithelial thickness maps. So there's really no reason that we don't have access to this in our practice. When you look at epithelial thickness and combine it with looking at curvature, the good news is not only that we can use this information to identify the ectatic cornea, but we can also use it to rule in patients for surgery that we have previously ruled out for focal inferior steepening. You can see with Placido imaging and Scheimpflug imaging, there's focal inferior steepening, but there's coincident epithelial hyperplasia. This patient is not a keratoconic patient. Another example of that, conversely, you can take patients with fairly subtle steepening, but with coincident epithelial thinning. This is someone we should avoid surgery. Many different patterns of steepening can be attributed to the epithelium. Corneal ectasias are focally focal disease processes. We've known that indirectly when we've looked at corneal topography. The more advanced steepening you have in one area, the more flattening you have in another. When we look at corneal tensile strength in the normal cornea, we know that there's a difference that is depth dependent. The anterior third of the cornea is significantly stronger or stiffer than the remaining cornea. Why is this? Well, this is at least in part due to the bridging fibers that we find in the anterior third of the cornea that are not present in the deeper layers and that are either found in less density or absent in the keratoconic cornea. So the pathology really appears to be primarily in the anterior third of the cornea. Looking with OCT elastography, my friend and colleague B.J. Dupes has done work showing that when you look at the keratoconic cornea as compared to the normal cornea, the real change is in the anterior portion of the cornea. The posterior cornea looks the same between patients with keratoconus and normal patients. Work done by Giuliano Scarcelli and colleagues has looked at the Brillion microscopy characterization of the keratoconic cornea. And as you would expect, when you compare the cone to the normal cornea, the cornea is significantly less stiff or weaker. But when you look at the non-conical region, it is really nearly identical to that of the normal cornea. So early on in the disease process, ectasias or keratoconus are primarily in the anterior third of the cornea and focal to the abnormal region. Corneal ectasias are inflammatory mediated processes, again, at least in part. Numerous papers over the years have looked at the increase in inflammatory mediators in ectatic corneas, and more recent work has really highlighted the reduction of lysyl oxidase in ectatic corneas, and specifically focal reduction. So when you look at the epithelium and the amount of lysyl oxidase expressed in the cone versus the periphery in the epithelium, they're significantly different. A recent case showing ectasia after small incision lenticule extraction with Rohit Shetty and colleagues looked at the expression of inflammatory mediators and found that in the ectatic patient, as compared to contemporaneous controls, lysyl oxidase levels were significantly reduced and TGF-beta levels significantly increased in the lenticules. Just as there have been many great steps, there have also been some missteps, primarily on the part of physicians, not so much researchers. We are all human. We want an easy answer. We want a roadmap that tells us exactly what to do. What are some of the missteps that we're looking at today? An overemphasis on machine-derived metrics. An overemphasis on the relative value of the posterior cornea in our assessments of early ectasias. And an over-reliance on current biomechanical measures. That's not to say that metrics are not useful, that the posterior cornea does not hold important information in our evaluations, and that current biomechanical devices have no role. Not to say that at all. But when we look at machine-derived metrics, an eye that says it was completely normal, but you can tell that the pattern is irregular and there is focal steepening, this patient would not be a good candidate for surgery and in fact developed ectasia after LASIK. A fairly recent paper looking at consensus opinions reported that abnormal posterior elevation, abnormal thickness distribution were mandatory to diagnose keratoconus, and that posterior elevation abnormalities must be present to diagnose earlier subclinical keratoconus. On the other hand, numerous authors have found just the opposite. A study by Bay and colleagues found that the anterior corneal curvature metrics successfully identified the highly asymmetric eye from normal populations, whereas the posterior surface metrics, enhanced screening metrics, did not. Another study found that the overlap in these populations was so dramatic in many of these metrics that they were not particularly useful. We had two recent studies on different cohorts looking at a similar concept of identifying highly asymmetric disease and looking at those eyes and comparing them to normal populations. And the bottom line was there were no individual metrics that performed well for Scheimpflug imaging or spectral domain OCT. When we looked at combining these metrics, the Scheimpflug did reasonably well, OCT did slightly better, and a combination of metrics from both devices were able to identify all of these patients. When you look at the relevant variables, many were point pachymetry measures. There were some anterior asymmetry measures, epithelial mapping measures that were critical. But there were no posterior corneal metrics that were beneficial for the models, and no enhanced ectasia screening. a similar cohort, different patients, but a similar concept, looking at dual Scheimpflug Placido analysis, found that 9 variables were the best combination to identify these patients. These variables in their relative rank were pachymetry, 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 and anterior surface irregular astigmatism. There were other metrics that were important, but much less so relatively. Is this patient a patient with unilateral keratoconus? That has been discussed. This is a patient that was identified in one of these studies. And in looking at the unaffected eye, over 6 months' time, there was no progression. So perhaps this is that patient that we can't identify because we don't need to. In fact, unfortunately, over the next year, the patient did progress and did have manifest keratoconus. This is exactly the individual we want to identify at the earliest stages so we can prevent vision loss. So when we look at the recommendations from this paper, while abnormal posterior elevation and thickness distribution may be useful, they are certainly not mandatory, and the anterior surface is certainly still extremely important. We look at new cases reported for ectasia after small incision lenticule extraction, and what these patients have in common is an irregular anterior curvature. This is a report that said there was no sign of forme fruste, but I would argue that in this right eye, that's an abnormal topography. None of these patients had normal topography. All of these patients developed ectasia after small incision lenticule extraction. So looking at our cases, is this case a good LASIK candidate? Well, there's significant focal steepening on the anterior surface. All of the other surfaces and metrics look fairly reasonable. This patient developed ectasia after LASIK, unfortunately, and when you look at corneal thickness, there's no information that jumps out at you. Nothing on the posterior surface, but the focal steepening is concerning and would have been concerning 20 years ago. So let's not ignore that. Does this patient have a corneal ectasia? I think most people would immediately say yes, of course, but the metrics are slightly more confusing. The same thing with this eye. Easy to identify subjectively, the metrics do not do so well. Which of these eyes developed ectasia after LASIK? Unfortunately, they both did. This is another 20-year-old male with asymmetric keratoconus. Which of these eyes progressed to frank keratoconus? Well, this patient did over the course of 18 months, while this patient had no progression over 3 years. So it's still difficult to determine. When we look at the biomechanical devices we have the ocular response analyzer and the Corvus. There are recent studies showing the benefit of, the additive benefit, I should say, of the Corvus device. But when we look at the patients that are hardest to identify in our practices, these devices still are adding very little to our evaluations. The patient I showed with ectasia after small incision lenticule extraction actually had normal biomechanical metrics. So what are the next steps? It's always exciting to talk about the next steps because you don't have to have any real data to support them. Genetic testing, biochemical analysis, and next generation biomechanical measures. Genetic testing, Avellino Labs introduced this in 2017. Well, maybe not in early 2017, but I know we've all thought about this, we've all been excited and then become less excited about the role of genetic analysis, but there do appear to be some genes that can be identified and that will be at least additively helpful. Rohit Shetty's group is looking at a point-of-care diagnostic device that will measure a variety of different markers in the cornea to give a good assessment of what sort of inflammatory status that cornea has. And then we look at what biomechanical devices may be coming. Specular interferometry is really being worked on by John Marshall and his colleagues. Again, BJ Dupe's lab is looking at OCT-based elastography and being able to look at the regional responses to deformation. And then again, my colleague Giuliano Scarcelli and I are looking at Brouillon microscopy and what we may be able to determine with that technology. So corneal ectasias are focally focal disease processes. This is the reason they are difficult to identify in the early stages. But now that we know that, we can gear our evaluations toward that. They are at least in part inflammatory in nature, both in terms of their development, but also probably in terms of their treatment over time. So what should we do to screen today? We should use multiple complementary technologies. We should use all data available, not just or even primarily the metrics that the machine gives you, and evaluate all corneal surfaces. Hopefully we'll be able to incorporate genetic testing, point-of-care inflammatory evaluations, and direct focal biomechanical measurements in the future. So again, even though we have much to learn, we do understand corneal ectasias better than ever. We have the ability to identify them earlier than ever, but it requires great training, great technology, and great effort on the part of the physician. There are no shortcuts. I'd like to thank the members of my lab, and thank you for your attention.
Thank you, Brad. That was outstanding. And again, another tour de force of our understanding of ectasia.